Welcome back, everybody. Good evening from Frankfurt in Germany. My name is Julian Chun. I'm head of cardiology at the CCB Markus Krankenhaus in Frankfurt am Main, and I'm very happy that we have such a fantastic panel today, and we will hopefully see a very exciting live case from Leipzig. And with me today is Isabel Deisenhofer. Isabel, she is head of the Department of Electrophysiology in Munich at the German Heart Centre. Also on board is Professor Helmut Pürrefelder, one of the leading experts in Europe and one of the most active electrophysiologists in Austria from Linz. Helmut, warm welcome to Austria. And I'm also very happy to welcome Dr. Afzal from London. He has a very long introduction. He is with the university in Barking, Havering, and Redbridge University and NHS and the Barts Heart Centre in London. Afzal Soeb, I'm also very happy that you are on board as well. And we have 1 hour with this very, very exciting session. And I think without losing time, we will now very shortly go over to Leipzig. And the idea is also for the audience to interact, ask questions, use the chat function, and we will try to answer and discuss all the questions which may come along with the very exciting case we are looking forward to. So, Leipzig, can you hear us?
Hello, good evening everyone, and welcome to Leipzig, the Heart Center. It was a quite spectacular and nice video presenting our center. We are also really happy to have this opportunity to show you the case tonight of pulmonary vein isolation with high power, short duration. It's a very hot topic in the electrophysiology, and also the names who are sitting in the as a moderators and chairs, they are also largely involved in the clinical evaluation of the high power short duration. So I expect a really hot and heated discussion. Before we start, I would like to introduce you the team tonight who are going to support us. Right on my side is Dr. Tim Zellwüster. Tim is one of our specialists here who is also a resident in the lab. He's going to present you also some of the details for the patient. Right behind him is Mark from Bioscience Webster, a really, really valuable and competent support and almost part of our team. And behind, of course, are our nurses, Johan and Juliane, very, very competent and also nice nurses who are going to take care of the patient, the sedation, and the stuff. So maybe I'll ask Tim first to present you some details for the patient, and then I'll explain something about the preparation.
Okay, thank you, Boris. We have a 57-year-old female patient who was referred to our center for paroxysmal AF. She has a CHEST-VEST score of 2 because of atrial hypertonus and female gender. We discussed with her prior to ablation possible medicamental antiarrhythmic therapy versus pulmonary vein isolation, and she decided to undergo pulmonary vein isolation. Prior to ablation, she underwent a cardiac MRI with LR angiography for a better left atrium measurements and anatomy.
Okay, thank you, Tim. Maybe you can see the three-dimensional reconstruction of the left atrium. Please, can you tell? Yeah, exactly. So that's how it looks like. Like the indication is pretty standard, but the anatomy, it's a little bit unusual. So she has like a long common ostium with a lot of branches, and also the right pulmonary veins are also like with a very short, like a trunks with a lot of small branches. So probably the anatomy would not be the easiest one to ablate. And you can also see the very, very large left atrial appendage line in front of this. Actually, the ridge is almost not existing. So yeah, maybe it's going to be tricky to ablate the isthmus. So is there any questions so far for the indication or for regarding the preparation?
Hi, Dr. Dino. I hope you can hear us, and thank you very much for this beautiful case presentation. And as far as I understand, so this is first-line therapy, is it correct? Maybe
yeah,
you
exactly.
can
That's the first line.
on your, let's say, philosophy in Leipzig regarding first-line ablation very briefly. And the second question would be, is it standard of care that you always do pre-procedural imaging so you know what to run into, what type of anatomy?
Mm-hmm. Thank you for the questions. They are, of course, very relevant also for us, but also for the EP community. So actually, our practice here in Leipzig for years was to perform a pre-procedural imaging. And in this case, you can see why. So, for example, this case, it's going to be really tricky for cryoablation. So it's going to be really fun to try to ablate all these small pulmonary veins and common ostium. So in some cases, it's going to be like a really of benefit for the electrophysiologist. But I should say the last couple of years, I don't think it's quite necessary, especially with the development of the new ablation systems and devices, and also the mapping systems with all new features like UniView and MediGuide and all the stuff. So you have a lot of possibilities to integrate the real anatomy and the pulmonary vein anatomy in your mapping system. So I don't think it's indispensable in this case, but I was pretty surprised or I'm pleasantly surprised to see this anatomy. So in this case, I expect to be really helpful. And regarding your first question, the indication for ablation, we are very meticulous, and we are very peculiar about the indications for ablation. And until recently, our indication was actually highly symptomatic pulmonary vein, highly symptomatic atrial fibrillation patients who were therapy refractory. So patients with refractory after antiarrhythmic drugs or cardioverted after the results of the EAST study. So we are pretty much relaxed now. So we also discuss the indication and the possible therapy managements with the patients. And of course, we involve also the patients in the decision. So I'm pretty much convinced that earlier pulmonary vein isolation could be beneficial for the patient. So if we discuss it with the patient in an appropriate way and give them the chance to also take responsibility in the treatment. So most of the patients actually decide for the pulmonary vein isolation as a first-line therapy.
I fully agree with you that offering, at least, and discussing upfront makes perfect sense. Maybe, of course, we want to see what you already did and what you already have achieved, or what you are going to do live right now. Maybe if you proceed, and in the meantime, maybe we can ask also the panel how the panelists will see it. Isabel, what is your opinion on the first-line ablation? Why we give Leipzig the chance to move on for their case?
Yeah, I think that's always a big question when you have patients before you. And I have to confess, we are quite liberal, have been always. So when the patients do not get really well along with beta blocker only and still have their symptomatic attacks, we don't insist them to try also class 1 or 3 antiarrhythmic drugs. As in many patients, the beta blocker alone won't be sufficient to suppress AFib. I think we have quite a number of patients where we did our ablation quite early. I think it's a different topic which was addressed in the EASE trial, when you really have a patient coming to your center with the first episode ever of AFib. Because looking at the statistics, it's quite depressive, because you know that probably this patient will have AFib then as a topic for the rest of his life unless you ablate him, but it's not 100%. So I think that's always then for us also the tough cases. But as I said, I think we are quite liberal, and I don't know, Helmut, how you do it in Linz.
Yeah, Isabel, thank you. The thing in Austria is that we're not living in Germany. And that's a big difference. That means that we have a longer waiting list. And if we have a waiting list of 5-6 months, then of course the question will not come up whether the patient wants to have an ablation immediately at once when the first episode has occurred, but when to do the ablation regarding to the waiting list. So there is, of course, this topic on in countries like mine. However, as a whole, I'm liberal, and this is supported by new data, as you know, from the cryo scene, that early AF has some benefit. So I'm liberal for that, and because of the RF ablation of PVI now being in a standard situation, so it's a standard approach with a standardized workflow, I think it makes sense to do it.
Helmut, I'm sorry to interrupt you, but I think Boris, Dr. Dinov is ready to move on, and I think we should give him a chance to show us what he is planning or what he is doing now.
Yeah, thank you very much. So I was waiting actually for the ACT. We already administered heparin, but I can tell you about the preparation steps. We saved you this boring preparation steps about the sedation and the groin puncture. Actually, we have a pretty slimline protocol in Leipzig. We introduced it 2 years ago, and for the sake of the groin complications. And as you can see, we on the picture, we have actually only 2 punctures of the right groin. We have, exactly, that's you can see the multiple CS catheter, and I already performed the transeptal puncture, single transeptal puncture, and that's it actually. So we monitor the blood pressure through non-invasively, usually by patients who are young, who don't have severe comorbidities, and who have unproblematic sedation. So I already administered heparin, and we are waiting for the ACT value. So the reason for that is we usually administer heparin before the transeptal puncture, before we go to into the left atrium. And I decided to use a catheter, which some of you already know. So that's the Q-dot catheter. That's it. That's a catheter. So it's a new catheter that we actually evaluated here in our center. That's how it looks like. Like on the surface, pretty much the standard catheter, but the structure of this catheter is a little bit different. So it has a different irrigation at the tip. It has an all-around irrigation, 30-60 degrees. Maybe we can kannst du noch mal spülen? Yeah. Maybe I can show it to you. I don't know if it's so it's quite different than the STSF catheter. Can you see it? Yeah. Dann geh mal weg. Yeah. So that's how it looks like. Okay.
Okay. Yeah, thank
So
you.
it's an
We can
all-around
see
irrigation.
like the surrounding flow. We get an idea. All right. And
Okay.
Boris, do you take baseline PV spike potential recordings with a spiral catheter, or do you rely on the power and the heat of your high power ablation, short duration ablation?
Actually, I will rely on the power and of the catheter. So before we were doing, and I preferred the double transeptal puncture, and also like lasso-controlled ablation, where you can like easily see the disappearance of the pulmonary vein potentials. But I should admit, so the last couple of years with the new powerful catheters, so for the most case of pulmonary vein isolation with paroxysmal atrial fibrillation, I don't think that's a pretty much like a benefit for the patient. You can spare like a double transeptal puncture. I guess I can. I hope I can demonstrate it.
I think we will be happy to discuss that later on, but please go ahead.
Yeah. Okay. So. Okay, the ACT is about 300 now, so I can go to the. Du kannst noch 3000 Heparin geben. Yeah, okay. So I decided to take the FEM anatomy with a ablation catheter, so I can see the signals. We can also use the lasso catheter, but in this case, with this pulmonary vein anatomy with a lot of small pulmonary veins, I prefer to do it with a ablation catheter, so I can make a really detailed FEM map of the left atrium, the pulmonary vein. So we can start. Ja, ja, ganz kurz. Du kannst auch the respiratory compensation. We'll take the respiratory compensation now. The first step is to insert the catheter in one of the pulmonary veins. In this case, is the left superior pulmonary vein. They will take the respiratory compensation with the system. It's going to take a while.
It's a very good trick to park it in the left upper vein, for instance. Otherwise, in our experience, we had to do it and repeat it a couple of times. So we do it exactly the same way. How about Afzal? What is your comment regarding this approach at this point in time?
Yeah, it's interesting to see that you've done it with a single transeptal puncture.
Okay.
Often the approach I've been used to, as you said you did previously, is to have two transeptals and the circular mapping catheter there at the same time, so you can see the signals disappear. So I'm fascinated to see how you proceed with this, Boris.
Geh mal auf 15 und nimm mal auch die
You also would go and rely on a lasso catheter for an RF case?
Yes, absolutely, yeah. How about you, Julian? Have you changed your approach yet?
I think I would also go for a double transeptal because I want to see the behavior of the potential in the pulmonary vein. But it's of course I know that if you're very skilled, and I know Dr. Dinov, he is very skilled. I think it is also feasible maybe, but of course my personal approach would be to have real-time visualization of the moment of isolation. I don't know. Yeah, this is how I would do it. Helmut, do you agree on this?
Yeah.
Of shifting.
The results from current trials are so compelling. So for kind of the close to cure protocols, I can see us changing our practice in time.
Yeah.
I think there is always the advantage to have this online monitoring of the vein behavior, as you said, Yongi, and on the other hand. You can then collect easily during you do your FEM map a multitude of also, let's say, wattage points. So you get a little bit to know more about that left atrium. What is it like? Is there a lot of scarring or anything? And of course, the electrograms that you can record with these multipolar small electrodes are if you want, so more detailed and better in a sense.
Dr. Dino, so what are you doing now?
Yeah, I'm obtaining now the geometry with ablation catheter. I'm trying to visualize and to depict all the pulmonary veins, and you can also see, so the left atrium is now appearing, so the long common ostium, and also all the branches and so on. So I don't need such a detailed map, but I'm trying now to, kannst du mir zeigen von Arrow von vorne, bitte? Yeah. I'm trying to find the left superior pulmonary vein, and now I'm in the the right superior, excuse me, the right superior pulmonary vein. Okay.
Just a question from here. I mean, you did not or use the force, so you don't know the contact force of your catheter. I mean, that's something I would, to be honest, use when I do my first sweep around in the left atrium that I didn't enter before, to know with the contact force of my catheter tip.
Yeah, thank you for the question. Actually, it's that's something that I actually rely on my tactile experience. So. But I will zero in the catheter before I start the ablation. Still, I'm quite gently, and I've elaborated like my own like approach. So I usually obtain the anatomy mainly with the catheter. So I'm gliding the catheter inside the pulmonary veins. So although I use the Gilles sheet, I don't make too much push with the Gilles sheet. I just glide the catheter inside, outside. I just steer the catheter to the front, to the back, and so on. But I don't make push with a Gilles sheet. So that's my approach, actually.
I mean, I'm completely okay if you do that, but I just wanted maybe to tell others that maybe who are not as experienced that they could use that contact force as an additional safety feature.
Sure, I totally agree. I totally agree with you. Okay, I'm actually fine with that anatomy for this patient. So maybe we can stop now. So now we have the FEM map. So it matches quite good the three-dimensional MRI. So we can also integrate both, but actually it's quite fine like this. So maybe you can just remove the CT image. For me, it's especially like useful, yeah, exactly, to obtain the reach on the front, especially in this patient with a really, really big left atrium appendage. So that's the, usually I orientate myself on the signals. So I watch the signals, and now I know where the end of the reach is, the end of the pulmonary vein is.
Maybe I can ask you, Dr. Dienhoff, to just briefly explain to all of us and all the audience the organization of your electrograms and what you look into and what we should look into during the next minutes.
Sure. So if you look at the signals, can you show the signals, please? The signals from the ECG signals? No,
EKG?
Yeah, exactly. So you can see now from starting from above. So you can see the surface ECG. There is lead 1, 2, V1, and V6. That's the normal surface ECG. Then you can see the MAP catheter. MAP 1 is a unipolar signal, and MAP 1, 2, that's the standard signal. But there is something interesting here, something new. That's a part of the new features of the catheter. That's the U1, 2, U2, 3, and U3, 1. These are the microelectrodes. These are the leads of the microelectrodes who are embedded at the tip of the catheter, which are pretty small, and they can ensure you like a high fidelity and high resolution signals. Sometimes you can see also in the pulmonary, during the pulmonary vein isolation, the signals from the pulmonary veins, how they go away from the main signal, from the far field signal, and you can also use it instead of lasso. So maybe that's going to be also like interesting for you, Julian, to see how you can see the isolation of your pulmonary veins with the help of these micro electrode signals during the ablation itself. So you can actually replace your lasso signals. And under these green signals, you can see the signals from the multipole catheter, from the CS, and that's it, actually.
All right, so very much like Leipzig, focused on the very much needed electrogram and information. So now, okay, what are your next steps?
Okay, my next step is to start the ablation. Before that, I will zero the catheter. Just let me find an appropriate position about it. Somewhere close to the mitral annulus and somewhere in the middle of nowhere. Maybe it's a small atrium. You can see somewhere here, yeah. You can zero the catheter. Okay. All right, and I can start ablation, and I will start like usual, like antral from the posterior wall. Yeah, fantastic. Any help? No? Okay, basically, you have two options with this catheter to ablate. The first one, you can choose between Q mode and Q mode plus. So the Q mode is the it's also a high power short duration mode where you use like a setups of 50 watts. You can use ablation index or just the time to limit your ablation lesions. And the temperature is set up at 50 centigrades. And you can also use the very high power short duration mode, the so-called Q mode plus mode, with 90 watts 4 seconds, which are actually presetted, and irrigation flow of 8. In this case, the temperature is set up at 65 centigrades, so it should not exceed the 65 grades. In this case, actually, I decided to perform the Q mode ablation, actually with 50 watts. And I will perform the ablation guided by ablation index. On the posterior wall, I will use, it's like a standard settings, ablation index of 400, so you can see here, and anteriorly 550. Okay. Do you have any?
Very briefly, why you select Q mode, not 90 watts for 4 seconds? What is the rationale in this scenario now?
Mm-hmm. So the rationale is actually we've been involved in the clinical evaluation of the catheter, and the last 8 cases that we performed with a very high power short duration, like 90 watts 4 seconds, I observed charring on the catheter tip in 4 of these cases. So that really concerns me. So I discussed it with Bioscience Webster. So we decided they're actually working on it they're working on this problem, but I decided for safety issues to perform it further with 50 watts and ablation index because I didn't observe any charring with this Q mode before.
Just a question.
I know some of you probably heard about that.
Yeah. Just a question, because the advantage of the Q mode plus would have been with this very high power that the lesions are really very, very, very shallow and you're just at the posterior wall. Do you have a possibility to export the location of the esophagus into your CARTO segmentation tool so that you know by the pre-procedural imaging where the esophagus might be? and then maybe use a lot of sort of less power or spare a little bit or something like that?
Actually, we have this opportunity, we have this possibility, but we discuss it with our people. We have actually our own MRI lab. And they were like pretty much skeptic about that because their rationale was that the esophagus is quite a structure which is very, it's not the same, it's moving. And their issue is that probably the position of the esophagus might not be exactly the same as from the imaging, pre-obtained imaging.
All right, I think
actually
we are now. Thank you very much for your explanations, and I think it's a very good clinical and wise decision to first of all collect and reconsider. But still, we are very interested in what you we were able to demonstrate for us with your still high power and short duration approach. So please move on. Also, in the interest of time, of course. We want to see some ablation lesions.
Yeah, sure. Let's go. What's the ablation index?
Coming in from the audience as well. I don't know if the panel have had a chance to look at some of them. There's some people who've mentioned ice. I don't know if any of you use ice for your ablation cases.
From the audience, and Dr. Bautista is asking and also suggesting to do 2 transeptals, but he is using always ice. So just a quick word on ice imaging and your or perspective on that.
Regarding the ice, so it's nice to have, of course. I know many centers who are using ice also for transeptal puncture and also to ensure the good catheter and tissue contact and so on. So we are not using the ice. We are actually very slimline. Of course, I know there are some people who are more friends and advocates of the more electrophysiological approach to the pulmonary vein isolation, but still my personal experience is that pulmonary vein isolation, just a simple pulmonary vein isolation, could be simplified to an anatomical approach. Completely different is the think about left atrial macrorental tachycardias or more complex arrhythmias. But we don't use ice actually in this.
Yeah. From my perspective, for daily routine cases, we don't use ice. We don't have ice. I fully agree. But this is maybe different between Europe and United States or North America, for instance, which is in which ice is typically utilized. Another just very brief maybe explanation regarding your sedation. This has also been of some interest from the audience. Is the patient in GA, or is the patient in deep sedation or in modest sedation, which may also interact? The catheter stability appears very good, so maybe just a quick word on that.
Yeah, okay. Regarding the sedation, so we usually use conscious sedation with propofol. We pre-administer midazolam and fentanyl. Of course, the good sedation, it's crucial in this case to achieve a good optimal catheter stability. The other key moment here is also the use of the Achilles sheath to stabilize the catheter. So we usually use the Achilles sheath. And in my opinion, it's a quite important actually factor who helps for the stability of the catheter. Kannst du mir von oben zeigen? Ja, danke.
Afzal.
Usually we administer fentanyl and propofol at the beginning, and if the patient starts moving during the procedure, we administer more fentanyl to better sedate the patient.
Yeah, thank you. Afzal, if you look at the
Kannst du mir
contact
LO
force
und von
posterior
vorne zeigen?
wall of around 8, 10, so what would be your thoughts on this? Would you go for more or for less? What would
in terms of
be your
force, in terms of contact force?
Yes, yes.
Yeah, I think 8 to 10 is. I think obviously my instinct is to be only enough force to do what you need to do. So definitely, I think 8 to 10 seems reasonable to me. I don't know what the view of the other panelists is.
I know with Helmut, we sometimes have some debates about the contact force, posterior wall, and the ablation. Well, how do you feel about this?
Yeah, well, my take is that I take around 10 to 15 gram on the posterior wall and sometimes up to 20 gram on the anterior wall and the ridge. However, I do think that, and I'm making up my mind in the last months using different technologies. I do think that contact force has a crucial role in catheter ablation. That's clear. I would not like to not have it. However, I think it's important to have a good contact and stability up front before you set the lesion. However, if you then apply the lesion, I think contact force does not have a big role any longer. So I think there is other things that are happening in the tissue with impedance, with current flow that are really determining the lesion and not the force during the lesion. That's what I think. I think that force is somehow overrated. That's what I think.
Yeah, I think one aspect is also that with these, maybe not with 50 watts, but with the extremely high power approach, if you have these higher grams, so a very good contact or even close to excessive contact, your risk of sympops will be significantly increased. And that's why when we use high power short duration approaches, we really aim to be below 12 to 15 grams. And as Helmut pointed out, I think that's the main point is that you are stable there and that you're touching the wall to some degree. And then maybe the formation of the lesion is depending on very different parameters that are not reflected by the contact force.
Sure.
But I think the high power approach that Boris so nicely now presents is it got us back to the physics, at least me. And I started to think a lot about when is a lesion forming and why do I have a larger lesion and less deep and whatever. So I don't know what's your feeling for the rest of the panel, but I got some lessons in physics back that I didn't take over the first 10 years of my career.
Yeah. Going back to the physics is, I think, a good key or a good word, because I think the colleagues from Leipzig, they prepared a small poll, and there is the first question in your poll. Is it correct, Dr. Dinov? Do you want to ask the poll, or do you want to read the poll, or your colleague maybe?
Maybe my colleague could read them.
Yeah, so you can continue working.
Yeah, sure. Thank you.
Wasn't he question?
Maybe you can show the questions.
Yeah, maybe we bring
because
it up.
we don't see them. Or maybe you can just read them for us, because we don't see them somehow.
We will bring up the questions, and the question, and I'm very happy that you brought up this, is how is the temperature, and this is for the audience, how is the temperature measurement with Q dot achieved? And is it A, using a thermocouple placed in the center of the catheter tip surrounded by saline? Is it B, 1 millimeter apart temperature sensors around the distal end of the ablation tip? Is it C, by 6 thermocouples placed distally and proximally at the catheter tip? And these are the questions, and I hope that the audience will be able to see it. We don't see it. The poll is live. Okay, the poll is live now. This I can at least see. A, thermocouple placed in the center of the catheter tip surrounded by saline. B, 1 millimeter apart temperature sensors around the distal end of the ablation tip, or C, 6 thermocouples placed distally and proximally at the catheter tip. So we will let at least 1 minute for the vote, and we come to the end of the poll in a second. All right, and Dr. Dinov has already almost closed one very nice circle.
Yeah, there is a small gap on the left superior pulmonary vein, which I can close soon.
Dr. Dinov, I see you using ablation index.
Of your local information from your catheter tip.
I'm sorry, I didn't hear the question. Somehow there was like a... Can you repeat the question,
there was
please?
an inferior gap. My question was,
yeah,
do you,
for sure.
do you judge that by the visual gap, or did you also see the local electrograms, which did guide you as well?
Okay. Actually, it's just a visual gap, and I will go with my catheter there, the visual gap, and I will actually look at the signals. And as you can see here, there are no signals at all.
We don't see any signals.
So,
we
although,
only see the cartoon.
Yeah, can you show the signals, please? The green signals? No, this, not this, the CCG. Yeah, so you can see now. So now I'm outside the circle.
We see that we don't see. Now get to see something, yes?
Now I'm going inside, and you can see here, actually, there are no any more signals. And you can see also dissociated signal. Do you see that? That was a dissociated signal, in my opinion, so you can see it also. Can you show me the cartoon map from above? Das LO bitte von oben.
Are now fairly small. Yeah, we see now the map catheter, and
now I'm outside.
Okay, now we see.
I can go inside the. You can see again. So I'm going into the pulmonary vein. So you can see the microelectrode catheters. There's a small spike. I'm not sure if it's a dissociated signal, but I can go close to the line now, to this visual gap.
Yeah.
And you can see there is a small local signal, but there is no signal of the microelectrodes. Maybe I can go inside again, just to go on the front gap here. And you can see there is nothing here, actually. Before, there were like clearly signals. I can also do now the control with lasso, so if you want. So we can prove that.
The audience also asked if you use pacing from the vein or other criteria like pace, maybe also pacing on the line.
We performed it before. Actually, I'm not quite a fan about that, because if you have capture in your pulmonary veins, so and you have a gap somewhere, you can have like a stimulus to like log stimulus to atrial capture. So you don't know actually where your gap is, especially if you have multiple gaps, which is usually the case. So if you have multiple gaps, it's not helping you at all.
Yeah, right. We have the poll back. And the poll is, you did a very good job in explaining in the beginning the type of the catheter. And the poll answered with 55% for question or answer C by 6 thermocouples placed at the catheter tip. So yeah, I think we all can see it now. So you did a good job in explaining the catheter. Thank you for that. Helmut, are you happy with the result on the left side?
You mean me?
Yes, Helmut. What do you think?
Are you happy? Well, I think the first pass isolation with this technique is very high. It's been shown that it's more than 90%, and I think he did it well. He used the 6 millimeter tag as far as I could see it. And with the settings that we have, so 400 on the posterior wall and even on the roof, I think he had the 400 and on the floor and the 550 on the anterior. There is a high probability that you will get the required and the desired result. I think this is a good way to do it. I think it is standardized now. It has an efficient workflow, and I'm quite okay with that, I have to say. Yeah. However, you know, if I think what I would really improve in the technique is to do it more tissue specifically, because I'm not sure whether every anterior ridge needs the same and every posterior tissue needs the same index. And I would be happy in the future to have it more tissue specific. However, for the time being, I think it's a very good method and he did it very properly.
Yeah, thank you. Afzal, from your side?
Yeah, absolutely. I wonder, did Boris, did you have any numbers in mind? Because just looking at how you put the color settings on your Visi tags, were you targeting 400 posteriorly, or did you have any other method for deciding when to stop your lesion?
Actually, we use, actually it's like Helmut said, it's a tissue specific. So we use the settings of 400 for the posterior wall and 550 for the anterior wall. And of course, they are differently colored. So the smaller the ablation index is, the lighter is the coloration of the points. So usually you see at the front, so they are like the bright red dots, and on the posterior wall they are like lighter. Of course, you can adjust all these colorations, color bars. Of course, I was a little bit distracted, I should say, from the question. So at some points, maybe I stayed a little bit longer at the posterior wall. I should say. But okay, now the lasso is in the left pulmonary vein, so in this common ostium, and maybe you can see the signals now. So you can see in my opinion, that's just far field potential from the left atrial appendage. So we already stimulated from the lasso with a high power, with a high output. We can do it again, just to demonstrate the exit block. 3, 4, 5, 6, 7, 8, 9, 10. Okay. Kannst du einmal bitte von CS 3, 4 oder sowas stimulieren? And can you measure it? So you can see, so the distance between the stimulus and it's quite short. So actually that's the left atrial appendage. I can also prove it when I now remove the catheter. Weiterstimulieren bitte. And now I'm at the left atrial appendage, so you can see it's the same, actually, distance. So it was a far field potential. So the left pulmonary vein was isolated with the first pass.
Absolutely. Super. Excellent. Thank you very much. And there's also an important comment, which is, again, commenting from the audience that, of course, it's not only the number of the contact force which is should be looked at, but also, of course, the graph of the contact force, and therefore is an indicator of catheter stability, which, of course, looking at your line was very, very good. So that was impressive. All right.
Thank you very much. Yeah. So shall we proceed with the right side, or?
Yeah, sure. Go ahead.
Just one question, maybe. Do you have a feeling how long you have to apply with these 50 watts to reach the ablation index of, let's say, 400, or is it 10 seconds? Is it 15? Is it less? Is it more? In average?
Actually, it's pretty. Yeah. Thank you very much. It's a very important question. Actually, I was pretty surprised at the beginning when we started to with this approach with Q mode. So actually, it took me like a couple of seconds, especially in the posterior wall, like 5 to 6 seconds for the signals to disappear. Actually, it takes a little bit longer at the front, but at the posterior wall, so you need like 4 or 5 seconds for the signals to disappear. Of course, it's not every case is the same. We have like patients with, of course, like hypertrophic cardiomyopathy or other patients where you take more, but in the mean patient is like that.
Dr. Dinov, in the meantime, while you prepare going over to the right side, I may bring up your second question, which you have prepared.
Yeah, thank you.
And I will read it for you, and I think the audience will get to see it very soon. The question is, how is target temperature with Q dot achieved? A, by manual power adjustment and constant irrigation flow. B, by continuous adjustments of the irrigation flow, and ultimately by automated power titration. Or C, by automated adjustments to the power output only. Okay, ladies and gentlemen, please vote. Okay, in the meantime, you already started again at the posterior wall, and this brings up another question from the audience. How about safety? Any safety concerns despite or maybe because of using high power with a short duration with regards to the esophagus? You don't use a temperature probe. This was one question. And another question related to safety. How often do you observe hemopericardium?
Okay. Thank you. That's, of course, a very relevant question. So actually, when we started with the high-power short-duration approach, we just abandoned the temperature measurement of the esophagus. So we asked ourselves, what should we do from now on? So we decided to perform routinely gastroesophagoscopy for all the patients who are ablated with a high-power short duration. So that's our approach now, and we are trying to gather some experience with this method. Until now, we haven't seen. Actually, I've seen one patient with like a really deep lesion of the esophagus. So we have to re-examine the patient 2 weeks after. So it was healing, fortunately, but we haven't observed any major complications until now, esophagus complications, fortunately, and about the hemopericardium also negative.
Just in our experience in Frankfurt, using a standard contact force STSF catheter and high power 50 watts, we couldn't do more with our type of generator. We observed 3.5% lesions in the esophagus and no fistula in a routine standardized post-ablation endoscopy. Okay. So now I observe or I realize, Dr. Dinov, that you started ablating at the posterior wall and at the posterior inferior part on both sides. In our hands, we would always start at the roof, especially in sinus rhythm at the left-sided veins, because we want to get rid of that early input in sinus rhythm from the Beckman's bundle. So we feel this is very helpful in order to make sure that we are on the right track. However, this requires elastocatheter to see the progressive delay during the ablation. Helmut, any comments from you? Where would you start? Do you start wherever you can?
Yeah, I start on the high posterior wall and normally then go down, but I do it without any reasoning that this should be better or worse than anything else. I think there is no good study on that. What really strikes me in the last months of my experience is that I get eager not to use a second sheath, because I think we don't need it any longer if we do high power short duration. I think it's one sheath is okay. Having two catheters still, so having a multipolar catheter to verify the vein and then have the ablation catheter, but I think one sheath is enough for that. Another point that I wanted to make is, in my experience of high power with 50 watt, I would not go over 10 seconds on the posterior wall, or very rarely to 12 seconds. So don't, if you use indices, don't be too low. Don't be for 3 or 5 gram or 7 gram, because then it would take longer that you get the index done. And I'm a bit cautious on that. So with high power 50 watt, I'm trying to restrict the duration of the burn to 10 seconds on the posterior wall.
Okay.
And this is for me a safety measure also for the esophagus.
Yeah, I think it's a very valid point. This requires, therefore, contact forces around 15 grams, and then you are done within 4 seconds, typically 4 seconds.
Exactly.
Yeah. All right. I've thought from your side, from the British UK experience, any other thoughts on this very beautiful case?
Yeah, it's really nice. I mean, I guess the rollout of high powered short duration ablation is still in its early days in the UK. But you can see its advantages there, because we've seen Boris isolate the left-sided veins very quickly, and you're probably competing in terms of time with what you can achieve with a cryo balloon as well. And if you can do it with one catheter and one sheath, like he's done here, then I think you can really see the attractions of this taking off.
But I'm sure, Isabel, if I ask you, again, regarding the question of 1 or 2 transeptals, I mean, if we may think with the patient turns an atrial fibrillation and then it changes to atrial flutter or some kind of atrial tachycardia, and we think of doing lines, and then we want to, of course, to have more information. Any thoughts?
I mean, I think what is interesting, because that's exactly what we reflect now as a panel, is that there are a lot of ways to get to happiness, and the beauty lies in the eye of the operator. We have a single transeptal puncture, but we cross then via the same hole 2 times the septum, and we have counterintuitively, we have the multipolar mapping catheter in the steerable sheath and the ablation catheter without steerable sheath, which is very well feasible now with these newer, a little bit stiffer ablation catheters. And I love this approach, because I have the feeling it gives me all the freedom. If I want to cross back to the right side, it's very easy. I have my 3 punctures in the groin. I just exchange. I go back to the left right atrium with my ablation catheter and so on. So I like this feeling of having all the options and all the possibilities. And as you, maybe I love also this moment when I see the change in the activation of the vein during ablation in the last 2 recordings. I think high power has changed a little bit for me, the feeling about how long should I stay in certain places. And as I said, I think we spend a lot of time on imagining what will the lesion look like that we create, and is that in that specific anatomic location of an advantage, or is it a disadvantage? So on the ridge, these shallow lesions are not helpful. I mean, because it's a thick tissue, and on the other hand, on the posterior wall, it's very helpful. So I think as I said, I started to think a lot about lesion and lesion formation and so on. And with this double access with 1 puncture, it's quite fast. It takes you maybe 1-2 minutes more to cross the septum. That's the second time. So it's not really something that is that I feel is cumbersome or so on. And then I have 2 catheters in the left atrium. It's very cheap. Why not?
Yeah, I fully agree. 2 catheters on the left side is of help, at least from my perspective. However, the poll came back, and the poll again answered to 55% the correct, and selected the correct answer, which was answer B, by continuous adjustments of the irrigation flow, and ultimately by automated power titration again. So the well-explained technology, and I think the audience got a pretty good idea of what you did. I am afraid.
One more, yeah? Okay. Julian, one comment. I mean, this is true for the Q mode, so up to 50 watts. And I think that's one of the problems with the Q mode plus, with a 90 watts that you have no adjustment of the irrigation. So there's no additional cooling of that tip, but only a power adjustment. And I think that's something that Biosense has to rethink.
Yeah, this is so you give us to the community, but also, of course, to Biosense, a little homework to do, and I understand. And I see that Dr. Dinov already completed his second circle. So I have to say a very, very fast bilateral circumferential ablation approach, despite of all the talking. I think that we are close to finish the session. And I thank you very, very much, Dr. Dinov, and your team in Leipzig. Beautiful presentation of this, very, very interesting and also daily life, maybe not, but changing technology itself, high power, short duration. And I think we will move on back to the next session, correct? And I think, Isabel, you will take over now the chair. Thank you very much to all my colleagues from the panel. And
thank you very much.
Regards.